we'll go ahead and get started. Welcome, everybody. My name is Nicole, and I'm with New Mexico's Primary Care Training Consortium. We are hosting the October didactic presentation today with Dr. Brant Hager. Thank you, Dr. Brant, for being here with us. And I'll just give you a little background on Dr. Hager. So he received his MD from the University of Rochester and completed a psychiatry residency and consultation liaison psychiatry fellowship at the University of New Mexico. He currently serves as an associate professor of psychiatry at the University of New Mexico and as program director of the UNM VA New Mexico Consultation Liaison Psychiatry Fellowship. His primary clinical appointments comprise the psychiatric care of people with HIV, the transgender, and gender non-binary people. His areas of interest include medical education, HIV psychiatry, transgender psychiatry, endocrine psychiatry, mood disorder, neuromodulation, and medical cannabis. And today he's going to be talking to us about weighing the risks and benefits of cannabis and treatment of chronic pain. Thank you, Dr. Hager. You can take it from here.
Well, thank you so much. Thank you for having me today. I really appreciate the opportunity to be able to speak with you all today. I'm a CL doc, and so I'm familiar with liaising with primary care providers. So it's one of my areas of comfort. So I feel very comfortable interacting with you all. We'll talk a little bit about cannabis risks and benefits in the treatment of chronic pain. Given that we have a relatively smaller group, I think we can probably shift the type of the presentation to one that's much more interactive. We can keep this discussion as interactive as you'd like. So I don't have anything to disclose. We're going to talk primarily about basic cannabinoid neurobiology pertaining to anti-nociception, and then talk about some of the relative efficacies of cannabinoids, opioids, duloxetine, pregabalin, NSAIDs, and so on in chronic pain conditions, to get a grounding of where it sort of sits. And then one of the hopes that I have is at the end of the talk, you could engage in some collaborative decision-making with patients who are requesting diagnostic certification for medical cannabis for a pain-related condition. And we'll talk a little bit about indications, efficacy, not FDA indications, but evidence-based indications, and risks and so on. So it's important to know that a lot of the cannabis-related literature focuses on its risks as a recreational or substance use disorder substance. And so the literature tends to be oriented towards the risks of cannabis. So there can be some of that bias in the literature. Some of the cannabis-related literature focuses on its therapeutic uses. And of course, that literature is increasing in volume as people access medical cannabis for a variety of conditions, some of which have evidence and others that don't. And then similarities and differences remain pretty unclear between people who use cannabis primarily recreationally versus primarily medically. And this can limit the external validity of some of the risk studies, and can limit the external validity of some of the benefit studies, because you're tapping into what may be different groups. Most studies of the therapeutic uses of cannabis utilize pharmacologically or pharmaceutically prepared cannabinoids. Most studies don't look at smoked cannabis flower or inhaled cannabis concentrates. Most of them are oral preparations. So there's limitations in the external validity of that literature to medical cannabis, which is oftentimes flower, sometimes concentrates that are vaped. And the cannabinoid content of medical cannabis preparations differs just on the face of things from that of the preparations that have been researched. There's a lot of cannabinoids, and we'll talk a little bit about all the different cannabinoids. And most of the research focuses on really THC, some CBD related literature, but mostly it focuses on THC. And the terpenes that are found in cannabis remain underrepresented in the therapeutic literature. So there's a lot of inaccuracies and grains of salt to take with all this stuff. So our bodies have a variety of cannabinoid receptors. The most common one is called the CB1 receptor. It's inhibitory G protein coupled, so it inhibits the metabolic activity of the cell to which it's attached. And it's mostly found in nerve tissue, brain, spinal cord, and peripheral nerve. It's also found in astrocytes, adipocytes, liver, pancreas, skeletal muscle, where it may have some role in metabolic processes. In fact, there was a CB1 receptor antagonist called rimonabant, which briefly was studied as a treatment possibly for weight management. And they discontinued the study because of the incidence of suicidal ideation in the active treatment arm. But blocking cannabinoid tone can lead to anorexia, or not anorexia nervosa, but lowered appetite. CB2 receptors, also inhibitory G protein coupled, primarily found in immune and inflammatory cells where they help to downregulate immune reactions. And they're also found in the brain and spinal cord, but it's not really clear what the role is in these areas under normal physiologic conditions. And then there are some other receptors, for example, the TRPV receptor, sometimes called the ionotropic cannabinoid receptor. And this stands for transient receptor potential vanilloid receptor. And this is a receptor that's involved in afferent nociception and the modulation of afferent nociception. So for example, when you stimulate TRPV receptors, you can get a nociceptive effect. And when you downregulate them, you can get an anti-nociceptive effect, in particular with regard to what they call protopathic sensations, so temperature and pain and temperature sensations. And this is primarily how the medication capsaicin works. It works as a TRPV receptor agonist. You stimulate those and you downregulate those receptors. And so then those small nerve fibers that transmit those protopathic pain sensations are less effective in their action. It also happens to be the mechanism by which people become accustomed to really spicy foods. So basically they're turning down the intensity of the efficiency of the transmission of that spicy food sensation. So they need more spice in order to get the same effect. Endogenously, we have two main cannabinoids. One's called 2-AG, the other one's called anandamide. 2-AG is a CB1 and CB2 agonist. It's rapidly released and it primarily acts as a retrograde synaptic messenger metabolized by COX-2 and MGL. Anandamide is also CB1, CB2 agonist, but it's slow release. Can act as more of a paracrine or autocrine messenger, sort of providing cannabinoid tone around the area of its release, not necessarily directly to just the nerve that is presynaptic, and is metabolized by FAAH. There's an irony in the name of anandamide. Does anyone know what the Sanskrit word ananda means? Ananda or ananda? So it's a Sanskrit word that means bliss. And this is part of the genesis of this idea, is that cannabinoids can sometimes induce euphoria in most people. The irony is that Ananda was also the name of the attendant, the monastic attendant of the Buddha, who was responsible for remembering all the teachings and passing them on as in sort of oral tradition. And if Ananda had been utilizing cannabis to a great extent, I think he would have had some trouble remembering all those teachings. So that's the sort of historical irony of the term anandamide. Here's some cartoon biology for you all. Primarily, I want to draw your attention to a postsynaptic neuron. They call it a neurone here because this is a British publication, so we'll be British here. So after a neurotransmitter is released and binds to a postsynaptic neuron, one of the mechanisms by which there's a negative feedback is the synthesis and release of 2-AG or anandamide following the excitation. This can go retrosynaptically to the presynaptic neuron, where it binds a CB1 receptor the CB1 receptor generally has a metabolic tuning down effect. It inhibits calcium channel influx, so therefore inhibiting further depolarization of the presynaptic neuron. It encourages potassium outflux, again, further discouraging depolarization of the presynaptic neuron. So generally, it's one of the mechanisms by which our brains maintain a negative feedback so they don't get overstimulated. There are various other receptors that act as autoreceptors on the presynaptic neuron, for example, and tune down this presynaptic neuron activity. But cannabinoids, endocannabinoids, are one of those mechanisms. When you have excessive amounts of CB1 receptor stimulation, essentially what you induce is an idiosyncratic imbalance of neurotransmitter release. And it happens to be in cannabis, or in the case of THC, that imbalance creates all the subjective effects of THC, the euphoria, the perception alterations, the time distortion, the hyperorexia, etc. But it's a state of neuronal imbalance, and we'll talk a little bit more about that when we talk about how it might be effective for pain. Some animal model data. There's some suggestion that perhaps cannabinoids help to inhibit localized inflammation and thus may inhibit nociception through diminishment of inflammation. Its role in this and anti-nociception in humans is not entirely clear. CB1 receptors are also found in dorsal root ganglion capsaicin-sensitive fibers, so not only the TRPV1 receptors found on those neurons, but also CB1 receptors that tend to tune down the intensity of those neurons functioning. Also found on Y dynamic range neurons. So these are neurons that transmit different types of pain. So just broad strokes. Capsaicin-sensitive fibers tend to be very small fibers, unmyelinated fibers, sometimes called C fibers. And those ones tend to generate some of the sensations of neuropathic pain, or the sort of like the burning, throbbing types of pain. And Y dynamic neurons, range neurons, are more sort of the zinging, sharp pain. It's an oversimplification, but those are some general broad strokes. You can also get decreased spinal cord NMDA receptor activation via CB1 receptors, and that's exactly what this is being shown here. You can basically diminish NMDA tone by inducing CB1 related negative feedback. And then you can promote stress-induced analgesia. There's something called the periaqueductal gray matter. This is continuous with a structure in the spinal cord called the substantia gelatinosa, and this is believed to be quite active in the transmission, especially of that protopathic pain, the burning and aching, throbbing pain. And cannabinoids may act on these multiple levels, basically inhibiting the transmission of, or the effective transmission of, peripheral pain stimuli, with a tendency towards affecting more of the protopathic pain stimuli rather than the epicritic pain stimuli. Here is an example of how cannabinoids may fit into the descending inhibition of pain stimuli. Here's 2-AG here. And if you have increased 2-AG stimulation, you will disinhibit the presynaptic GABA release. Rather, you will inhibit the presynaptic GABA release, you'll disinhibit the presynaptic GABA release, which will in turn decrease the effectiveness of the neurons that are transmitting the pain. You can see here that here's arachidonic acid, here's the COX enzyme, here are opioids, and their effect directly on arachidonic acid. So applying cannabinoids at the same time you're applying opioids can make sense in terms of you're going in two different directions to try to inhibit the transmission of painful stimuli in the spinal cord. You look at higher order brain functioning, one of the things that administration of THC in particular appears to do is it appears to dissociate or disconnect the attentional system from the somatosensory system. In this study, they used the anterior cingulate cortex as a seed, meaning this is the area that they compared the relative activity of other areas to. And the anterior cingulate cortex is a relay station for a lot of different neuronal activities, primarily a relay station for interplay between emotion, attention, and higher order cognitive processing. And in this study, what they showed was that the placebo group didn't have a decrease in their visual analog pain scale. This is neuropathic pain. The cannabis experimental group, the THC experimental group, did have a diminishment in their visual analog pain scale. And this correlated with a change in the connectivity between this attentional node and these somatosensory nodes. So not only is there a diminished efficiency of painful stimuli making it to the brain, in the brain, there is a disconnection between attention and the higher order conscious awareness of pain. So it's in a sense diminishing caring about pain, diminishing attending to pain. In a similar way, subjectively to how opioids do, the pain is still there, but you can just sort of ignore it. So this may be part of why it has anti-nociceptive effects. There's also the effects of the euphoria that is induced oftentimes with cannabis intake. And sometimes there can be a misattribution. So attributing euphoria, if you're euphoric, you're a little bit less likely to care about pain. So there can be a misattribution that the euphoria is a part or necessary for the anti-nociception, but it is probably in addition to other anti-nociceptive mechanisms.
I have a quick question.
Yeah, go ahead.
I sometimes feel like pain reduction is also similar to this this disinhibition that you're talking about, or the you care less about the pain as associated with opioids.
Yeah,
I feel like many times the opioids are effective just because people they hurt, but they care less about their pain. I don't know if that's something that you've seen.
well, I think opioids, if we look back to the previous slide, we can see that opioids also have some role in tuning up descending inhibition of painful stimuli. So it's probably a similar kind of bimodal mechanism as we see with cannabinoids. It just so happens that, fortunately, cannabinoids don't appear to suppress respiration. So that's, in terms of a safety profile, they have a broader safety profile from a lethality standpoint, but there are other safety risks associated with the cannabinoids. I think your observation is spot on.
Okay.
Other questions? Okie doke. We'll continue on. So plant-based cannabinoids or phytocannabinoids. So there's THC and CBD, which are two main ones. There's dozens of other ones, but these are the ones that have received the most attention. THC is a CB1, CB2 partial agonist. It's also a GPR55 agonist. This may play some role in its seizure-related mechanisms of action. CBD tends to block the effect of CB1 and CB2 receptor agonists, although it doesn't appear to have direct impacts on CB1 or CB2 receptors. CBD is also a TRPV1 agonist, very similar to capsaicin. It's also a serotonin 1A receptor agonist, which this can have anxiolytic properties or antidepressant properties. Some 5-HT1A agonists can have those properties. It's an alpha-1, alpha-3 glycine agonist. This may play a role in some of its anti-seizure effects. It inhibits the anandamide breakdown. And then it blocks these resurgent sodium currents in these particular sodium channels. But this may be one of the core features of why it's effective for Dravet syndrome and other forms of juvenile myoclonic epilepsy. And then it's also a potent 2C19 inhibitor and a less potent 3A4 inhibitor. And in the studies of its use in Dravet syndrome and Lennox-Gastaut syndrome, most of those patients were also taking clobazam, which is metabolized by 2C19. So part of CBD's efficacy in those syndromes may be a boosting of clobazam relative dose in addition to direct anti-seizure effects. So THC is seen as much more straightforward. CBD is more like a THC playground minder, sort of tuning it up a little bit here and tuning it down a little bit there. From a practical standpoint, what it looks like neurobehaviorally or behaviorally, psychologically, is CBD tends to attenuate some of the adverse subjective effects of THC or the adverse neuropsychological effects of THC. And this could be one method of risk reduction for patients who are taking medical cannabis, is the supplemental administration of CBD. And then synthetic cannabinoids, you've probably heard of spice and K2. Nabilone is also a synthetic cannabinoid that's available as a treatment for chemotherapy-related nausea and vomiting. Spice and K2, one of their problems is they're CB1, CB2 receptor full agonists, and use of these compounds can go pretty quickly from euphoria to psychosis to agitation and delirium. And some of the worst deliria that I've seen in inpatient settings has been in the context of spice or K2 intoxication. Dexanabinol is a synthetic cannabinoid, but it's not active at CB1 or CB2 receptors. It's actually an NMDA receptor antagonist. It was studied to see if it could help with post-TBI recovery and was not found to be effective for that. So some of these preparations are FDA approved. These are the FDA approved preparations. Dronabinol is essentially synthetic THC. FDA approved for HIV-related anorexia or wasting or chemotherapy-related nausea and vomiting. Nabilone is a THC analog. It's about 5 times more potent than THC. It's FDA approved for chemotherapy-related nausea and vomiting. Cannabidiol is FDA approved specifically for seizures due to Dravet syndrome, Lennox-Gastaut syndrome with tuberous sclerosis. And then nabiximols is a 50-50 THC CBD transmucosal spray that's available outside the US for MS-related spasticity, but for some reason they haven't gone for an FDA indication. And most of the studies of cannabinoids in the context of chronic pain have involved synthetic THC, and some have involved some cannabidiol, and some have involved some nabiximols, but very few have involved smoked cannabis. One of the things I like to share with people is that medical cannabis may be either, both, or neither. So dissecting this, medical cannabis may be either, so it could be certainly cannabis, but may not have medicinal use for that particular indication or certifying condition. It may be both cannabis and have a good use, or it may be neither cannabis nor have a good use. The reason why I say this is because cannabis preparations, plant-based cannabis preparations, have undergone massive transformation over the course of the past 30 years. So looking here in 1993, this is 8% THC of different preparations, all domestic and non-domestic. Now, this was cannabis that was seized. This is illicit cannabis. And you can see how the THC content of cannabis that was seized has risen over 5 times between 1993 to 2008, and this trend has continued to go up. So it's not uncommon now to see cannabis preparations with 20%, 25%, 30% THC content. In the illicit market, this was mostly driven by non-domestic cannabis. But what you'll see in medical cannabis shops is you'll see a lot of preparations that have a ton of THC and not much CBD, and maybe the shop pays a little bit of attention to the terpenes. So the medical cannabis that's available today bears very little resemblance to wild type cannabis. And the doses of THC that are ingested for many people taking medical cannabis far exceed those doses that have been studied most robustly. And the whole thing about medical cannabis may be neither. The cannabis preparation may not resemble wild type cannabis at all, and may be used for a certifying diagnosis that actually has no empirical evidence behind it. This has to do with the structure of the medical cannabis program and how certified diagnoses are added. Questions before we continue on? Okay, so neuropsychiatrically, THC in the acute state tends to induce psychotic symptoms. Sometimes these are pleasant psychotic symptoms like perceptual disturbances, time alteration. Sometimes it's very unpleasant like psychosis, like paranoia. It tends to increase the physiologic correlates of fear responses. So this is SCR, skin conduction response. So if you expose somebody to fearful faces under the influence of THC, they tend to have more of a physiologic fear response. It tends to impair verbal learning, short-term memory, working memory, and attention in the acute phase. And it tends to increase striatal dopamine by 2 to 5%. This is similar to the amount of dopamine release that's found in other pleasurable activities like food ingestion, sex. Nicotine also increases it by about this amount. Alcohol, cocaine, methamphetamine increases striatal dopamine about 10 times that much, which may be why methamphetamine can be so difficult to interrupt, methamphetamine use. And then chronically, THC ingestion tends to induce psychotic symptoms, reduce both glutamate and GABA levels, which makes sense because it's a retrograde synaptic messenger that does negative feedback. And then it tends to decrease hippocampal volume and gray matter concentration and then downregulate cortical CB1 receptors. The body becomes tolerant to it. And then if you stop cannabis, you can get a cannabinoid withdrawal, which can last for a couple months. It takes a while for the CB1 receptors to bounce back. CBD, in turn, tends to attenuate THC-induced psychotogenic and memory impairments, and decreases the physiologic signals of fear that can be induced by THC. And so CBD given at the same time as THC may limit some of the adverse neuropsychiatric effects of THC. So this is a risk reduction you can do with your patients, is encourage them to supplement with some CBD simultaneous to the THC. And then chronic CBD ingestion tends to attenuate some of those brain shrinkage problems and attenuate THC-induced psychotic symptoms. It can be difficult, though, to find preparation in the medical cannabis industry to find 50-50 THC CBD preparations. Most of the time, it's like just a whiff of CBD, and people are really paying attention to the THC. This is DSM criteria for cannabis intoxication. This is the good, the bad, the ugly. Euphoria, calmness, sociability increase, some of these color perceptions and so on, ostensibly considered to be the good. The bad, cognitive impairment, judgment impairment, motor coordination impairment, the ugly, panic, paranoia, hallucinations, and so on. So it comes all together. And some people get more of some than others. Some people tolerate cannabis very well and only get the subjective positive effects. It's idiosyncratic. Cannabis withdrawal, as with most drugs, is usually some of the opposite effects that you might see in intoxication. So people get more anxious, irritable, angry. They tend to have disruptions of their sleep. Their appetite goes down. They feel restless. Sometimes they feel depressed. Sometimes they can get pain and tremors and sweating and headache and so on. This tends to take the CB1 receptors tend to re-regulate in about a month. So the cannabis withdrawal can take weeks to a couple months to fully run its course, and it tends to subside gradually. So moving on to some of the epidemiology of cannabis use, it's the most commonly used illicit substance. And of course, we have to be careful with our terminology now because it's legal to use, purchase and use in New Mexico and many other states, still illicit from a federal standpoint. And the use appears to, at least back in 2016, appeared to be highest in not super young, but younger age groups. One of the challenges is that cannabis use disorder can occur fairly commonly in life, and about 9% of first-time recreational cannabis users will eventually go on to develop a cannabis use disorder. So it's not without risk from a use disorder standpoint. Medical cannabis is not without risk from a use disorder standpoint. And what we found is that recreational cannabis use at baseline is associated with subsequent development of a variety of other substance use and psychiatric disorders. And then there are also the vice versa, several psychiatric disorders at baseline are associated with an increased risk of subsequent recreational cannabis use and the development of a use disorder. So there's a bidirectional risk. And it's not clear whether this risk with baseline cannabis use and then follow-up having these other risks is it's not clear if these are just folks who have some tendency towards getting into a cycle of addiction, and therefore they have an increased risk of using other substances. Are these folks who have some disturbance at baseline that's sub-threshold and they're using cannabis to try to regulate emotion? And then at follow-up, their disorders more fully get realized? Or is it something that is unmasking an underlying tendency? So that's the belief in things like schizophrenia and bipolar disorder, is that people who have high risk at baseline for that, cannabis use can unmask that, and the disorder can persist past the cessation of cannabis. There's also some correlates to be aware of. So lower birth weight in infants of mothers who have used cannabis during pregnancy, and some increased attention and behavioral problems in their offspring. Hard to tell how much of this is sort of nature and the direct effects of cannabis in utero versus nurture within the family environment. People who use cannabis, especially earlier, tend to have poor cognitive, academic, vocational outcomes. There is an increased risk of motor vehicle accidents. And this is something that I think we need to be aware of on a public health standpoint. In localities where cannabis has been legalized, there is an increased incidence of cannabis-involved motor vehicle accidents. It oftentimes is a combined substance intoxication that leads to a motor vehicle accident, so cannabis plus alcohol. And cannabis intoxication will impair motor coordination and judgment to a degree that's commensurate with around the legal limit of alcohol. There also is an increased risk of MI and stroke with acute cannabis use. The risk lasts for minutes to hours after cannabis intake. This may be maybe due to the increased cardiac workload. People use cannabis and they have tachycardia as a result, and that could put people at greater risk for developing ischemic disease. It may have to do with cannabis-induced inflammatory effects on endothelial cells in coronary vessels. Ironically, cannabis tends to exacerbate a lot of courses of PTSD. And this is ironic because PTSD is the #1 diagnostic certification condition for cannabis, medical cannabis in New Mexico. So I caution a lot of people in terms of utilizing cannabis for the treatment of PTSD. It does appear clearly to exacerbate schizophrenia, bipolar disorder, and depression. And there is a correlation between cannabis use and completion of suicide, unfortunately. So you all are probably familiar with these things like number needed to treat, number needed to harm, standardized mean difference, and weighted mean difference as measures of effect size. So we're going to get into some of the evidence base for cannabinoids for particular conditions. Here's some examples of small, medium, and large effect size. And it's just important for us all to remember that most treatments for chronic medical conditions have small to medium effect sizes, and we have to apply multiple of them to get the desired effect. These are examples from general medicine and psychiatry. I'll send these slides out after the talk, so you'll have the slide deck. So here's a summary of the efficacy of cannabinoids for chronic pain. If you look at just reduction in pain in general versus placebo, people in the active cannabis group, and this is particularly THC, tend to have a greater odds of a 30% or more reduction in pain with a number needed to treat of 11, and tend to decrease their pain on a 10-point rating scale by an average of half a point relative to an active comparator like placebo. The standardized mean difference in cancer pain is 0.76. That's a modest effect size relative to placebo. And in non-cancer pain, mostly it's neuropathic pain with another modest effect size. There's not mixed trials, but mixed trials in fibromyalgia, mostly negative trials in MS-related pain, and there are trials with osteoarthritis and migraine underway right now. And like I said before, the vast majority of these studies use THC alone or synthetic THC alone, or maybe like in the nabiximols. Very few studies use cannabis flower or extracts. Negative studies of CBD in osteoarthritis and low back pain. So sometimes people say, okay, use CBD for pain. So far, CBD hasn't shown much evidence for the treatment of any sort of pain condition, unfortunately. And perhaps not surprisingly, the active arm in these THC trials has shown greater adverse effects than placebo by about a factor of 3, and 3 times more people in the active arm are 3 times more likely to withdraw than people in the placebo arm from these trials. And now these trials are done in people who don't have cannabis use disorder, so this is a different population than recreational cannabis users. Here's a list of a variety of other adverse effects, and essentially their odds ratio relative to placebos over here. So 5 times more likely than placebo to experience dizziness and so on. Interestingly, people put euphoria as an adverse effect. They're 4 times more likely to experience euphoria. For some people, unexpected euphoria at a time that they don't want it can be an adverse effect. So suffice it to say that THC has more adverse effects than placebo, and the effect sizes are modest in the treatment of pain conditions. Here's some comparisons. Opioids versus placebo in non-cancer pain, chronic non-cancer pain, about a similar difference, a weighted mean difference on a 10 centimeter visual analog scale. So about a half a point less than the placebo group. And low back pain, here's NSAIDs for low back pain, also showing about a half a point difference in a 10-point visual analog scale. Painful diabetic neuropathy, similar relative rates of, or relative risks of 30% or more reduction in pain with pregabalin, as we saw for THC. The 50% reduction in pain was not reported for the THC studies, but here the numbers needed to treat and the relative risks for pregabalin. Here's duloxetine, which appears to have a smaller number needed to treat for reduction in pain, for 50% reduction in pain for painful diabetic neuropathy, and about a 1-point difference on a numeric rating scale. So for example, if you're trying to order what would be most effective for neuropathic pain, like painful diabetic neuropathy, you might put duloxetine as a number 1, and then pregabalin, THC as like a number 2. Here's some neuropathic pain from mixed causes, looking at tramadol, and you can see the relative risk of a 50% reduction in pain and a number needed to treat there. And tramadol is associated with its own issues. So in general, THC containing products at doses that usually are less than those ingested by folks who take medical cannabis tend to have a modest benefit on the treatment of chronic pain conditions, including cancer pain, non-cancer pain, neuropathic pain. The majority of the evidence is in neuropathic pain, and it has adverse effects that need to be taken into account. So here's some outstanding questions. Does medical cannabis reduce risk of opioid overdose? This is getting at your concerns, Ned. Does medical cannabis reduce opioid use? And does medical cannabis treat opioid withdrawal? And the answer appears to be no, no, and no. So we'll look at the evidence for each of these questions. So there was a lot of excitement generated by this ecological study on the impact of medical cannabis laws on opioid overdose deaths. So states with a medical cannabis law, there was a lot of states with medical cannabis law that they instituted the laws here around 2008, 2009. And from 2009 to 2010, they saw this drop in opioid overdose deaths at the same time where states without a medical cannabis law saw this increase. It generated a lot of excitement, like, can we use medical cannabis as a means, a public health means of diminishing opioid overdose deaths? And turns out that if you continue to follow this trend, the same group followed this trend, the trend reverses over the course of 2008 to 2009. But if you continue going on, the states with the medical cannabis laws on the books actually start to increase in their rates of opioid overdose deaths. And this is the problem with ecological studies and interpreting ecological studies, is that ecological effects do not necessarily reflect effects on an individual basis. So probably not effective for reducing opioid overdose deaths. In order to study this, we would have to randomize people with opioid use disorder or who are opioid pain medications to receiving THC or not receiving THC and study how many of them die. Does cannabis use diminish the risk of developing opioid use disorder? From a recreational standpoint, it appears that the answer is no. This is a study called the National Epidemiologic Study of Alcohol and Related Conditions, and they did 2 waves. On wave 1, they assessed cannabis use and how much cannabis was being used. And wave 2, they assessed whether or not somebody developed an opioid use disorder. And you can see as the level of cannabis use in wave 1 increased from no use to occasional use to frequent use to very frequent use, the subsequent development of opioid use disorder increased in prevalence. Or I'm sorry, I should say in incidence. So at least as it pertains to recreational cannabis use, baseline recreational cannabis use tends to be a correlate of later on developing an opioid use disorder. So will cannabis legalization diminish the transition of people from not having to having an opioid use disorder? It's anybody's guess. But this evidence suggests that probably the answer is no. In contrast, there are some studies that look at people with chronic pain conditions who the MCP group is the medical cannabis program group, and the comparison group is people with chronic pain from a variety of sources who are not in the medical cannabis program group. And over the course of about a year and a half, this study essentially found that the people in the medical cannabis program group gradually diminished their mean daily morphine equivalent doses, whereas the people in the comparison group experienced a relatively flat rate of opioid dosing. So, is it possible that people who use medical cannabis for pain-related conditions and don't have a recreational cannabis use concern could serve as an opioid-sparing effect for those populations? And that's a really good question, and I think that the jury is still out. This is a forest plot of animal data that suggests that the animals that were given morphine plus THC had less pain-related behaviors than the animals that were given morphine plus vehicle. And so this is some suggestion that maybe THC can have an opioid-sparing effect. But if you look at human clinical studies, only 1 of 9 human clinical studies showed an opioid-sparing effect or a diminishment of the opioid dose. And these are randomized controlled trials. So maybe in some people, it can reduce the amount of opioid that they take, possibly. but the evidence is not very robust about that. And then does cannabis treat opioid withdrawal? And the answer in brief is no. This is opioid withdrawal scale, and this is opioid withdrawal from methadone. And these are opioid withdrawal scales over a course of days in people with cannabis use and people who don't use cannabis use, and the scores look exactly the same. In contrast, people who have heavy THC use versus non-heavy THC use tend to drop out of opioid replacement therapy at a greater rate. This may be a reflection of greater psychological distress and less likelihood of staying engaged in care. So one of the questions that comes up with this is, so say you have somebody with opioid use disorder and medication-assisted therapy who's engaged in treatment and is not a heavy cannabis user. If you encourage them to use cannabis, does it change their dropout? And I don't think anybody knows the answer to that question. But so far, what we see is that it doesn't appear to facilitate engagement in opioid use disorder care or reduction in the withdrawal state. So here's some highlights about recreational cannabis versus medical cannabis in New Mexico. It's the same plants, same preparations, same safety testing, same safety parameters. Recreational cannabis is taxed, it's age restricted. There are limited amounts per purchase, but unlimited purchases. You can drive from place to place and buy an unlimited amount per day. Medical cannabis is untaxed, it's not age restricted, requires diagnostic certification, and it does not preclude the purchase of recreational cannabis, and there's limited amounts per time period permitted for medical cannabis in New Mexico. So slightly different regulations around these things. Here's some suggested cautions and contraindications for medical cannabis use. I would suggest that if somebody already has a cannabis use disorder, that may be a contraindication to medical cannabis use. If somebody has a pretty clear history of bipolar illness or schizophrenia, or is active in suicidality, I would suggest not certifying for medical cannabis use. Use prior to full neurodevelopment is also suggested as a contraindication. I caution people when they want to use cannabis for PTSD, because the evidence is not very robust for that. In fact, there's evidence for it being potentially harmful in PTSD. People with severe depression, if they have a non-cannabis substance use disorder, if they have high cardiovascular or cerebrovascular risk, or if they've got chronic bronchitis and they're planning to use smoked cannabis. And medical cannabis is just like any other sort of drug preparation. It has its risks and benefits, and we need to be versed in these risks to be able to educate patients about them. And I do encourage collaborative decision-making with patients about possible risks. So if they're bound and determined to utilize medical cannabis, and they get diagnostically certified by another doctor or another practitioner, I will work with them to try to minimize the risk. Like, for example, please don't drive while the intoxication effects are active. Let's keep an eye on your psychosis. Let's keep an eye on your mania. Let's keep an eye on your suicidality. Let's keep an eye on your anxiety and PTSD. And if these things tend to get worse, let's make some different decisions about this. So I don't cut people off who go down this pathway. I try to keep them engaged in care in a harm reduction fashion. I also encourage people to supplement with CBD in order to attenuate some of these adverse neuropsychiatric effects. And it's important for them also to continue concomitant standard pain rehabilitation and palliation strategies. Successful pain condition treatment is multimodal, with each modality adding a small effect, and then working in concert to help the patient. So this is my summary slide. I'm just going to leave this up and let's do some questions. So what questions do folks have?
I have a few questions, actually, just one question. One of the areas for advisory caution with using THC was chronic bronchitis for smoke.
Yeah.
I was just curious, do you see that with other types of COPD? Is emphysematous changes, asthma? Are there any other concerns that we need to think about?
It's a limitation of the literature that really focused in on chronic bronchitis as a definition of a risk. It's interesting in asthma. in asthma, for some reason, cannabis intake doesn't appear to regularly worsen asthma. And possibly because there's irritant effects and there may be anti-inflammatory effects going on at the same time. And why it would worsen chronic bronchitis but not asthma, anybody's guess. It's been surprisingly devoid of adverse respiratory problems or respiratory cancer-related problems. A lot of people who smoke cannabis also smoke cigarettes, and so that's probably the bigger risk.
Okay, that makes sense. I think a lot of the frustration that we have, and you mentioned it, is just due to the lack of research, the lack of data, and we're just learning about it. One thing I did not realize, and I think this is very important, is the significant difference in the medical preparations versus the desiccated flowers or more natural preparations. And I also understand some of the newer available preparations also have a much heavier THC component than CBD component. And it's really interesting because we don't know anything, and we're just learning that the that ratio makes a big difference.
Yes.
And so I think that I learned from this talk, which was very significant. So when you talk about supplementing with CBD, how do you do that, and what does that look like?
Well, the first thing I'd encourage people to look for flower preparations or concentrate preparations that have a 50-50 mix. And some people do sell these preparations. They tend to be more expensive. Or I try to get a sense of, like, say somebody's smoking 20% THC flower and they go through 1 gram per week. So that's 200 milligrams of THC per week. And let's just round it up to 21 so it's easy to do the math. So would that be 14 milligrams per day. And then I would say, okay, well, let's supplement with 14 milligrams per day of a CBD tincture that's under your tongue.
So you're trying to approach that 50-50 mixture.
Yeah.
Very, very interesting. Other things I thought that were important, typically when I talk about pain reduction to my patients and starting on whatever medication for pain reduction, I think the first thing I always discuss with them is that typically you can expect a 30% pain reduction. That complete pain relief is not an acceptable expectation, because we don't have that ability to do that. And some of the data you demonstrated show that I guess it was THC specifically was in that range for specific medications, which is interesting. I know when THC became a significant, or became legal in New Mexico specifically for medication usage. We used it a lot in our residency to reduce opiate use. And the early literature said that was as much as 70% reduction in opiate use. But the charts to show that shows over time it may not be true per se, which is very interesting. But I think the other case that's important is we didn't know how effective it was with pain. And it looks like there does play a role, which I think is really an important consideration when we're prescribing for chronic pain use.
Yeah, absolutely. Yeah, it can be a useful tool.
Yeah, absolutely. Ned, it looked like you were going to say something, and I kept talking, so I didn't want to step in.
Actually, you asked some of what I was interested in. I guess I end up talking to prescribers more and more now about screening for cannabis use. Recreational use, and I guess I need to learn a little bit more about CBD. I mean, I think the most interesting comment to me was, in terms of the practicality of all this, is combining people who are using recreational cannabis with CBD in the context of what we're talking about, and the potential use it could have in downregulating some of the pain perception of folks, or at least if they still have the pain, they don't care about it as much as it is with narcotics. But understanding the percentage of cannabis in the CBD and having people understand the percentage of THC in the cannabis that they're buying recreationally, I mean, that requires I think, a certain level of sophistication that patients don't have about other prescribed medications that they are taking as well, unfortunately.
Yeah.
So that leads into a whole discussion of health literacy, and how do we communicate all of that to patients, and the kind of time it takes. And then knowing if people are coming in for pain, whether they're using recreational cannabis, what they're using it for. I mean, it's complicated, but I think it's something that, I mean, I'm finding I have to address this fairly frequently now.
Yeah.
With the primary care providers that I'm working with, and this will give me a little bit more specific information if it's approved by the consultants to our project to use this information as part of our education of these folks.
Sure.
So thank you. It was very helpful.
You're welcome. Thank you.
I know we're at close to the end of our time. I just also wanted to say, I really appreciate the comment on PTSD. And I think it's so much of the initial rules that came out around THC were based on very weak evidence. And for us, we actually use it primarily with cancer diagnoses and with pain associations. But PTSD, I think, being the most commonly prescribed indication in New Mexico, when it actually puts people at risk, is, I think, is very important to know, and will be shared with my group. And thank you for that.
You're welcome.
And I wonder, just as one final comment about this, people may be self-medicating with cannabis now that they can buy it recreationally and not even come to prescribers for a card, except they're not paying tax.
Mm-hmm.
Is going to be the main difference practically for them. It'll be less expensive for them, but people may very well be using it on their own based on whatever they read somewhere.
Yeah.
Great. Thank you so much, Dr. Hager. Any closing questions, comments?
Nicole, I wanted to share the slides with you, so maybe you can distribute to the group, and please share my email as well. People are welcome to reach out.
Awesome, thanks. That's much appreciated. And we'll have the video up on the website too, if you want to share it with your residencies.
Oh, cool.
Thank you, guys.
Thank you, everybody.